Hello everyone, this is Dr. Pruitt. Welcome to this week's EKG. Our case today is a 70-year-old male who calls because he's having chest pressure, and he says he's been having chest pressure since yesterday, but it's gotten to the point where it's just unbearable now. He's got a history of type 1 diabetes and acid reflux. The initial vitals on scene look pretty good. He's got a heart rate of 53, so a little bradycardic. Blood pressure 125/73, oxygen saturation is great on room air, and his blood sugar looks normal. This particular crew did a very good job of getting a 12 lead within 2 minutes of their arrival at the patient's bedside. And I'll give you a second to look at this, but that turns out to be a really important metric for them. So as we go through this together, we do it the same way every time. We start with our rate. So I usually let the computer do the work. We've got a rate of 54. I'm just going to confirm that with my eyes here. Find a QRS complex that matches up with a thick red line. Then we count down 300, 150, 100, 75, 60, and then we're below 60, between 40 and 60. I'd agree, somewhere around 54. So we'll call our rate 54. As we move on and we look at our rhythm, we ask two questions here. Is there a P wave before every QRS? And then is it regular or irregular? So just looking with the naked eye, it looks pretty regular to me. I don't see any big gaps, any kind of accelerated complexes. I would call it regular. As we're looking for P waves, the best place to see P waves is in lead 2. So look here. I do see them, but there's a little bit of a long interval here. So I'm going to cheat and look at what the computer tells me. And sure enough, our PR interval, the distance between the P and the first part of the QRS complex, is long at 242. But I'm still going to continue looking for P waves all the way across with every beat. Before every QRS, there is a P wave. So this is a sinus rhythm, but I'll call this a first degree AV block because the PR is greater than 200. Okay, and we do have a regular rhythm. As we move on through our methodical way of looking at 12 leads, next we are going to evaluate our axis. So this is where we look at leads 1 and leads AVF. If you remember, lead 1 is your left thumb, lead AVF is your right thumb. We're looking at the majority of the QRS vector here. So in lead 1, it's mostly up. Our left thumb is up. That's good. Lead AVF, this is clearly mostly down. So we have our left thumb up, our right thumb down. We've got left axis deviation here. And then as we progress through our 12 lead, we're going to look at our intervals. We let the computer do the work here. Our QRS is 128, so that a normal QRS is less than 120. This is just barely wide. We always look at V1 here. I won't get into the details here, but it doesn't quite meet criteria for a bundle branch block, but what this suggests is there's a little bit of an interventricular conduction delay. That's why the QRS is wide, because it's not sending down the signals as fast as normal with a nice strong QRS. It's a little bit wide and it's a little bit delayed. And we'll talk about why in a second. And then next, we look at our QTC. It's 430. That's less than 450. I'm happy with that. So we have a bit of a wide QRS with a QTC of 430. And then as we move on to our ST segments, this is where we're really going to focus today. So I always look in my territorial leads first. We do the same way every time so you don't miss things. 2, 3, and AVF are our inferior leads. And here's where we're going to look at our ST segments. And what I see here is some pretty significant ST depressions with T-wave inversions, okay? You see how those T-waves are flipped and that ST segment is below the baseline there. Next, I move to 1 and AVL. These are the high lateral leads. There's a little bit of elevation there. It's very subtle. This one's close to the baseline, but AVL doesn't look perfect to me. As I move to the septal and anterior leads, oh my goodness, what are we seeing here? So if we look at the baseline, we've got ST elevation in V2, V3. I would call it elevated there too, with some depression starting to show in V5 and V6. And so what we have here is a STEMI. And so I would agree with the computer because we've got greater than 2 millimeters of elevation in our anteroseptal leads with reciprocal changes, meaning ST depressions and T-wave inversions on the opposite side. And so what that looks like, what this is telling you, if you remember, where your leads are placed, it matters where we put those stickers, right? And so V1 and V2 are your septal leads, if you remember. So the heart, we know it's divided into the right and the left side. So this is the left side over here, it's the right side over here, and you have that big muscular septum going right through the middle to help divide the heart. Well, leads V1 and V2 are going to be able to tell you what's going on with that muscle in the septum there. Whereas V3 and V4 are a little moved towards the left, and they have a really good view of this big major artery going down the heart, the left anterior descending artery. And so that's why we call that those are the anterior leads, because they're looking at the front of the heart, the left anterior descending, where V1 and V2 really have a good look at the septum. And then 5 and 6, as you move over towards the armpit, they're looking at the lateral side of the heart. So they can tell you a lot about the circumflex artery, or maybe even higher towards the back up near the left main. And that's where you get into 1 and AVL. Out here, some of your limb leads are also looking at those high lateral areas of the heart. So just a little anatomy review there. Well, what we're looking at with our STEMI here is because we had elevation in V1 through V4, we've got involvement of an infarct in the septum and also this big anterior wall here. And this is likely a blockage in that big left anterior descending artery, which you hear referred to as the widowmaker. You can imagine this is the main artery that helps that left ventricle pump blood to the rest of the body. So if that gets blocked, people can die very quickly. And so that's what we're seeing here with the elevation in V1 through V4. We're seeing the reciprocal changes. If you look at leads 2, 3, and AVF, we call those the inferior leads. So if you're seeing elevation here, just the mirror image of that, kind of on the back side, is going to be the ST depressions and T-wave inversions. And that's why that makes sense anatomically. So in order to meet criteria for a STEMI, you need 2 millimeters of elevation and 2 contiguous leads with reciprocal changes on the opposite leads. And this is what a STEMI actually looks like on somebody's heart. So this is a pathology specimen, and you can imagine taking the heart, cutting it in half, and tipping it sideways. So you can see the big, thick left ventricle here, right ventricle here, a little thinner, doesn't have as much muscle. But as we look and then anterior is the bottom side here, posterior is on the top. And you can see this person had an anteroseptal MI. So the anterior wall, right where that left anterior descending artery would feed, and then also the septum here is involved. And you can see how that muscle is black, is dead. It doesn't look like healthy muscle. That's infarcted tissue. And immediately it looks kind of black like this. Over time, if this person was to survive this heart attack, it would turn to like white fibrous material. But you can see this was a very big infarct as well. And so I really want to remind you here on these 12 leads, any STEMI is inherently unstable. So the first thing you want to do once you recognize it, get your 12 lead early. The minute you recognize a STEMI, call a STEMI alert, get that cath lab mobilized, get them to the hospital, get them ready to go, ready to meet you there so they can reperfuse this heart as fast as possible. But in the meantime, these are inherently unstable, so get those pads on there. These anterior STEMIs tend to devolve into ventricular dysrhythmias, and that makes sense because it's mostly the left ventricle that's involved. So I would anticipate, think through how you're going to treat this patient if they go into ventricular fibrillation or ventricular tachycardia, and have those pads on and be ready. The other thing that we do that helps with mortality is that aspirin. If our dispatchers didn't already get them to take that before you got there, make sure they get that 324 of aspirin before they get to the hospital. And then here's one last look at our 12 lead. What we have is a sinus rhythm, right, with a first degree AV block, because we got that long PR. Leftward axis, slightly interventricular conduction delay, and that starts to make sense, right? Because we have a big STEMI that's infarcting those conduction pathways, and so we're starting to see signs of conduction delay with our long QRS here. The other thing that we're starting to see, and I didn't really get into, is these Q waves here. This means that some of the tissue is already dead because he waited a little while to call. But the big thing here, we see our AnteroSeptal STEMI with the ST elevation in V1 through V4 and the reciprocal changes in 2, 3, and AVF. So this is a STEMI alert. Thanks for your time, you guys. I'm looking forward to seeing you next week.